First of all, I would like to say Assalamu alaikum, good evening, good morning, good afternoon for all those that are hearing us. I would like to thank Novartis for giving us the opportunity to moderate these sessions. And I have a pioneer speakers today with me also to present a very interesting topics. And the first speaker it will be Dr. Ahmed Al-Barqi. Dr. Ahmed Al-Barqi, he is a well-known veterinary surgeon, assistant professor of ophthalmology. He is a veterinary consultant in MC Sheikh Khalifa Medical City.
And Dr. Mohammed, I think it's sure
yeah,
it's
please,
another.
Stop sharing. This one is not different session, please. Okay, no problem. Faculty member of ISASO, and he's working in Sheikh Khalifa Medical City. And Dr. Ahmed, he is going to give a talk about case presentation in AMD and DME. Dr. Ahmed, the mic with you, please.
Okay, thank you, Dr. Mohammed. And it's a pleasure to be here today with you and with Prafan and Ibrahim. And thanks to Novartis for the invitation. I'm going to share now my screen.
Yes, please. Yes.
Okay, so I'm going to share a case. This patient is a male patient, 72 years old, diabetes for a long time, with hemoglobin C8, another comorbidity, cardiac and hypertension, and he's complaining decreased vision in the right eye, but it's a long story. This is not the reason he's coming to my clinic. He has also a history of intravitreal injection in this eye. So in examination, the visual acuity in the right eye was hand motion, and the left eye was quite good, 20/25. Intraocular pressure was normal, IOL in both eyes, and he has dense subretinal fibrosis secondary to the AMD or wet AMD complication. And he was coming just for regular follow-up to check his diabetic and his retina. So in examination, as you can see, the OCT of the left eye, there is nothing normal except for these RPE changes here. So we agreed that we control the blood sugar and the follow-up every 3 months. And 3 months, he came with a bit decrease in the vision, 20/30 instead of 20/25, but the patient was not complaining. And if you look at the OCT at that time, you can see this mild cystic changes here in the retina and with this hyperreflective dots. So just to tell you about the patient was too much concerned about his seeing eye, and he is rejecting any kind of treatment because he lost one eye and he thought that the treatment was the reason for that. So, so psychologically, you have to deal with the patient, that's okay. So I offer him that this is start of the problem in your left eye, and we need to give injection or give treatment, either injection or focal laser. But the patient, he said, I can see well, and he refused the treatment, and he asked, we agreed on, okay, if you refuse the treatment, let's have a close follow-up on a monthly basis. So the patient was coming for a monthly follow-up, and the next month, actually, he have a more blurry vision in the left eye, the vision dropped to 20/40. And as expected, the edema increased in the eye and encroaching on the fovea. And you can see there's still hyperreflective dots there. So at that time, the patient actually agreed for the treatment to keep the vision. And I will start with him intravitreal anti-VEGF. I start with Prolozumab. And after first month, there is some improvement in the edema, but not the vision is the same. And I just want to have a look here that there is some changes here is going on and increasing the level of the RPE elevation and some erosion there. Second month, the vision improved to 20/30 and the edema is improved also. And you can see also here the edema there is not there or improving. Third month was a very good result, and we returned to the baseline visual acuity 20/25, and the patient was happy. I discussed with the patient that in those cases, we need to treat and extend to keep the eye dry or keep the macula dry. But again, the patient, he was refusing any treatment as long as he's seeing well. So again, we agreed to follow up the patient monthly also, because a single eye patient. So he was doing okay until 6 months later. He came with 20/30 and another area of RPE elevation here at the area with some divisionoid there. So, and the vision dropped a bit, but the vision was not complaining. 4 months later, as expected, the vision dropped, and we can see here some vascular membrane here and subretinal fluid, and the vision dropped to 60. At that time, the patient for sure agreed to treatment. So we start with him with Ranibizumab, and after 3 monthly injection, you can see here, vision is still the same, and edema a bit less, but it's still some edema there, and starting to form this subretinal hyperexcited material. And after 3 months in injection was the result. So I decided actually to switch to another anti-VEGF with aflibercept. And those patients actually I switched early because considering the need of the patient and the single eye patient, so I don't want to waste my time for giving more injection and does not have response, so better to switch early. We can discuss this also at the discussion. So I give him, the plan was 3 monthly injection and followed by monthly for the first year at the protocol of V1 and V2. And he received 3 monthly injection, and this is the result. Edema is still there, and vision is not improved, and the shrimp is still there also, but a bit better. So we discussed with the patient that we are with some case of stability, so I can give the injection, the fourth injection after 2 months. So after 2 months, patient came for the injection, but you can see here how big the subretinal fluid and the larger size of the shrimp, and the vision dropped significantly. And at that time, actually, we are still starting the treatment of aflibercept, and he should receive the fourth dose with this increase. So I think there is non-responsive to the drug. So at that time, the Prolozumab was available, and I used it already in some patients. So I discussed with the patient that we have to switch to another molecule, and this is just this OCTA to show you the neovascular stuff there. So we start with him or Prolozumab, and I give him the injection. 2 weeks only after the injection, you can see the dramatic improvement of in terms of fluid, but you can see here the shrimp is still there. The vision improved 2200, but still not the perfect vision. So we keep injecting the patient. And the 1 month post-injection, it's a bit more improvement in the vision, no fluid, but still the shrimp there. So this is 1 month post second injection. Also no improvement in the vision, but still dry macula. And just to show you before and after the 2 months of injection, there is somehow decrease in the size or the thickness of the shrimp before and after 2 months injection. So just to there's some, we'll discuss this later on also, but this was a bit decreased in the size. This is 1 month post the third injection. So we complete the loading dose, and vision is still the same, and it's expected because of the shrimp. So now I decided with the patient that let's follow up now. We do the injection after 2 or 3 months according to the activity. Patient came after 3 months, stable, nothing changed, and we have to give injection, but the patient refused, and I said, okay, let's wait and observe monthly. Interestingly, actually, this is 6 months post the third injection. No activity, vision the same. There is a mild bit increase in the thickness of the shrimp there, but 6 months dry. And this is maybe we discussed that. So with my colleagues, should they continue the intravitreal injection of Prolozumab or observe? If we have a stable, he received 3 injections and he's dry now for almost 9 months. 6 months, sorry, post the injection. Just to have a very quick comment about the shrimp, because we all know that from CAT trial, it has a poor prognosis regarding in terms of visual acuity. So the thickness and the presence of shrimp associated with poor visual acuity. And there is a recent postdoc analysis of Hook and Harrier data. They look at the quantitative metrics for the OCT grading, and you look at the thickness of the shrimp and the macula and the foveal center together with the PED type. And they found that with PVU or Prolozumab, you might have some improvement in the thickness of the shrimp if you continue treatment. And but in my case, there was not too much improvement actually, but at least it was stable. And this is, I think, the point of discussion. If you have time, thank you for your attention, and they can ask my colleagues about what you're going to do in this patient if you want to continue the treatment or you observe, and just your thoughts about the case.
Thank you very much, Dr. Ahmed. Very interesting case. Is there any question, Dr. Prasan, or comment? I think Dr. Ibrahim is here also with us.
I have the question.
Yeah, please. Okay,
I need a comment. Yeah, to know, do you continue treating the patient or stay as long as the macula is dry? Do you treat the shrimp or you wait? So
Dr. Ahmed, very interesting case. As you titled it, it's dual pathology. The patient started with the DME and then progressed to neovascular AMD. In my opinion, I think considering that he's got a very bad history in the other eye where he landed with a disciform scar, I would be more keen to continue the treatment, especially because he's one-eyed. I know the patient might be a little reluctant to take injections even if he's stable, but if you compare the last two images, actually there's a little increase in the thickness right above the area where there's a shrimp in the outer retinal layers, which basically indicates that probably there is some leakage happening, though it's extrafoveal, which also indicates that there could be presence of.
We cannot hear you, Dr.
Prasan, yes. I thought from my side. Prasan, we cannot hear you.
Are you using AirPod?
If you can, please, maybe you press on.
Yeah, he's not muted, but I think the.
No, not muted. This is a laptop, a computer. He pressed something, maybe mutant. Okay. Or maybe I think the.
Can you hear me now?
Yes.
Can
you hear me now?
Yes.
Perfect.
Yes. So I think, sorry about that. So let me just rephrase, let me just continue from where I started. So if you look at the last two images, you'll see that this patient has an increase in the thickness of the outer retina right in the layer of the nasal part of the shrimp, which would basically mean that he's probably having some exudation. It would be better to continue the.
Okay, Dr. Ibrahim, maybe you join us a little bit late, but
I joined a little bit late. My apology, because unfortunately they sent me the wrong email that the meeting will be tomorrow, 11th.
Tomorrow,
yeah. And I received it this way, and I wasn't prepared at all, and then suddenly.
But I think they inform you from the Novartis. It is today, and anyway.
No, it is not, but when they send the official email for the joining, this is 11, so that's fine. But anyway,
so you have to pay for this mistake, Dr. Ibrahim.
Okay, that's fine. I'm prepared.
Anyway, because we are also short on the time, maybe we can take now Dr. Prasan and we can have a discussion at the end. If we can go very fast on the presentation, so we can have more time for discussion. So the second talk, it will be by Dr. Prasan Rao, and it will be about why fluid matters in DME. I think also in AMD, or you are going to take only in DME?
Only DME. So only am I audible and my slides are seen?
Yes. Please go ahead, Dr. Prasan.
So at the outset, let me thank Team Novartis and thanks Dr. Ahmed and thanks Dr. Ibrahim and Mohammed for giving me this opportunity. So I'll be talking on why fluid matters in DME. So as you are all aware, the accumulation of the fluid in the layers of the macula is a ubiquitous manifestation of various retinal diseases. And the interstitial space of the retina is normally maintained dry. However, various mechanisms can cause breakdown of the outer retinal barrier, and this leads to retinal edema and eventually visual loss. So DME, as we know, is characterized by abnormal accumulation of fluid in the intraretinal and the subretinal space, which causes the retinal thickening and leads to distortion of the central vision. So we are all aware that in patients with diabetes, increased blood sugar level is associated with advanced end-stage glycation products, which lead to damage to the retinal microcirculation, leading to increased vascular permeability, leakage of the fluid, and finally, this disruption of the retinal architecture leads to compromised visual function. So we see two types of fluids in patients with diabetic macular edema. We have the intraretinal fluid or the intraretinal cysts, and the location of these and the size of these intraretinal cysts not only correlates with the visual acuity at baseline, but also correlates with the anatomical response to treatment. So if the cysts are located within the inner retinal nuclear layer, they're more responsive to the injections as compared to cysts which are located in the outer nuclear layer. What about subretinal fluid? Subretinal fluid is generally associated with late onset or delayed course of DME, and this leakage occurs from the microorganisms in the inner nuclear layer, and then it spreads to the subretinal space, leading to major disorganization of the retinal structures. So if you look at various studies, both IRF and subretinal fluid are associated with disease activity, but a lot of studies have shown that the intraretinal fluid is more prevalent. For example, in Hawken-Harrier, almost 100%, and Apollon study, which is a real world evidence, which showed almost 95% of these patients had intraretinal fluid. So more intraretinal fluid as compared to subretinal fluid. Also in general, what happens is if you have reduction of the retinal thickness with anti-VEGF treatment in DME, this is associated with improvement in vision. So if you look at the RESOLVE study, on the left, you'll see the graph where there's a mean change in BCVA with intravitreal injections of ranibizumab. The dark the dark blue graph shows a predominant increase in the visual acuity, whereas the light blue is the one in the sham group where there's reduction in the visual acuity. Similarly, if you look at the CRT changes on the OCT, the dark blue circle and line of the graph is indicated of the intravitreal injection, and you see a progressive decline. And so this mirrors the improvement in the visual acuity. An illustrative case here is on the left side, you see a right eye being treated with intravitreal injections, and with progressive intravitreal injections of ranibizumab, you can see a decline in the central retinal subfield thickness, and also you can see resolution of the fluid with improvement in vision. On the right side, you see an eye which is in the sham group, which had persistent fluid and progressive drop in the vision. So there are various international guidelines provided by the various societies, the International Council of Ophthalmology, Royal College of Ophthalmology, URETINA, and the AO. All of them recommend the use of OCTA to assess and monitor and evaluate response to therapy in DME. So what do we look out for in the OCT? We look at central subfield thickness. So these are the various studies. The criteria for retreatment is based on whether the CRT is increased by 500 micron or it is worsened by 10%, or you can also look at absolute values where the CST is more than 250 microns if you're using a SD-OCT, or if you're using a SWEP, time domain, it's 250 and SD-OCT is 300. So what is the role of retinal fluid in DME? You have various locations. As I mentioned, it can be serous macular detachment, intraretinal cysts, and also if it is associated with vitreomacular traction. We also see sometimes hyperreflective spots, which are indicative of chronicity. And you also want to look at the ISOS layer, whether this is regular or it's distorted, because this has a prognostic value. So if untreated, the subretinal fluid leads to a loss of vision in DME patients. And this was clearly demonstrated in Rise and Write post-hoc analysis, where they showed that patients with subretinal fluid at baseline were 4 times more likely to experience a 3-letter drop in the sham group. What happens to SRF with respect to the baseline vision and improvement in vision? So SRF is associated with worse baseline best corrected visual acuity, as shown in the post-hoc analysis of protocol T. So eyes with more subretinal fluid had lesser vision as compared to eyes without SRF. And what happens to the reduction? With reduction, every 10 nanoliters of reduction of SRF is associated with an improvement of vision of about 0.3 letters on the ETDRS scale. And now let's look at intraretinal fluid. So if untreated, the presence of intraretinal fluid in the macula is associated with poor visual outcome. So again, you look at Rise and Write trials. If untreated, the patients with IRF at baseline were 4 times more likely to lose vision as compared to the eyes without IRF. IRF again at baseline has worse vision. So if you look at protocol T post-hoc analysis, this is the mean IRF at baseline. You can see more eyes had worse vision as compared to eyes which had better vision. So the presence of IRF.
If you can please conclude, because we are having
yeah,
please. Okay.
Sure. So okay. So if you look at the chronicity, again, you look at if the fluid is chronic, untreated eyes usually result in gradual loss of vision in these patients. Early treatment of macular edema is important in DME patients to prevent avoidable visual loss, and significant number of patients will continue to have persistent fluid. Persistent macular edema leads to lower visual gains. And finally, to conclude, fluid in DME matters because the fluid accumulation disrupts the anatomy and causes visual loss. We know from Rise and Write that early treatment is important in DME. IRF and SRF are associated with worse visual outcomes, and DME patients with persistent fluid will have lower visual gains compared to those who have early resolution. And finally, reduction of IRF and SRF is associated with improved visual outcome in DME. Thank you for your kind attention.
Thank you very much, Dr. Prasan, for this excellent presentation. We want just to move to the second, last, not the least presentation by my dear friends, Dr. Ibrahim. Dr. Ibrahim Al-Gharabi is a vitreoretinal consultant, Eye Institute at Cleveland Clinic, Abu Dhabi, and he is going to present his presentation. It will be about the future in DME management. Dr. Ibrahim. Dr. Ibrahim, please. Yeah.
Thank you for the invitation, Dr. Mohammed. Thank you for Novartis as well. As you say, just I'm going to present the outcome of Kite and Crystal studies for diabetic macular edema. Let me see, I cannot run.
Okay, Dr. Ibrahim is there. You can.
Yeah, okay. As I said, these are two phase 3 trials to evaluate the efficacy and safety of Prolozumab in treatment of patients with visual impairment due to diabetic macular edema. They've been run over 36 countries. Crystal was mainly in America and Australia, and Kite was the rest of the world, and has been conducted over nearly 197 sites in patients with diabetic macular edema. The primary objective of the study is to demonstrate that the Prolozumab is non-inferior to aflibercept, and the endpoint was to change from the baseline in best-corrected visual acuity at week 52. And of course, there was some secondary objectives, including the anatomical outcome, non-inferiority of Prolozumab to aflibercept regarding the visual acuity during the last 3 months treatment. Also, to estimate the proportion of patients treated on Q12 with Prolozumab and whether it will work or not, to evaluate the functional anatomical outcome of both Prolozumab versus aflibercept, and also to evaluate the safety. Quality of life was one of the issues to be evaluated, and there was a specific for Kite to assess the potential to extend the treatment intervals on the second year over the 3-month period. There was inclusion and exclusion criteria. Any patient with diabetic macular edema involving the center, and best corrected visual acuity lie between 78 to 23 letters will be involved. And patients, for example, with the previous treatment with steroids or active the proliferative diabetic retinopathy or prior anti-VEGF therapies were excluded from the study. This is the study design. Usually we start with 5 loading doses, and every 6 weeks in case of Prolozumab, and every month in case of aflibercept, and after this, patients will stay in Q12. However, if any patient at the assessment visits or the assessment visit showed any reduction in vision, it will be moved to Q8 in a Prolozumab arm. The assessment of disease activity was done at a certain period, as I mentioned before, it is mainly at week 28. And there was some criteria to say whether there was a disease activity or not, and according which, whether should we continue in Q12 or move to Q8. So these are the results. This is the demographic or the baseline characteristic across the treatment arms. And in Kiss and Cat, the primary endpoints have been met with the 6 milligram, and it was non-inferior to aflibercept at week 52. Whether 6 milligram or 3 milligram of aflibercept, they managed to improve the visual acuity, which was maintained till the week 52. There was significant improvement in the...
Dr. Ibrahim, can you go faster, please, if you don't mind?
Yeah.
Behind the times.
Yeah, there was definitely improvement also on the central macular thickness, and it was more obvious with Prolozumab 6 milligram. And the more Prolozumab treated eyes achieved less than 280 compared to aflibercept. And fewer patients on Prolozumab had subretinal fluid and intraretinal fluid, so it was even better in improving the central macular thickness compared to aflibercept. More than 50% of the patients maintained in Q12, which is a good outcome compared to aflibercept. And from the safety profile, it was comparable. There was no big issues or adverse side effects. In conclusion, Prolozumab 6 milligram was non-inferior to aflibercept in the mean change in the best corrected visual acuity. There was significant improvement in the central subfield thickness from baseline were achieved with the 6 milligram especially. There was a higher proportion of patients with fluid resolution, whether it is intraretinal fluid or subretinal fluid, on Prolozumab 6 milligram at week 52. More than half of the patient who were on Prolozumab arm 6 milligram maintained on Q12 treatment interval up to the week 52, immediately after the loading phase. And overall, the Prolozumab had a well-tolerated safety profile. So thank you.
Thank you very much, Dr. Ibrahim, for this excellent presentation, as usual.
No,
because we are
I wished it. Sorry for any inconvenience. Just it came as a quick, and I'm prepared with anyway.
Not a problem. We know you, Dr. Ibrahim. You don't need it. Thank you very much. Because we are running behind the time, and there is 1 minute already from the next session, but we will ask one questions, and it can be for all. When we are treating a diabetic macular edema per se, not or in AMD, is there a problem to keep some fluid if there is no change in the response in the either in the fluid or in the visual acuity? Everyone can give opinion.
Okay,
Ibrahim?
quickly, diabetic macular edema patient.
2 seconds.
Yeah, exactly. I was like, and 1 second, diabetic macular edema patient can tolerate some fluid compared to AMD patients. And definitely, they can maintain stable visual acuity even if they have some fluid over a long time. And I think this was, if I remember, it was protocol S outcome as well, or protocol I can't remember, but definitely they can maintain some fluid without having any big problem with the vision.
Okay, Ahmed?
Yeah, I believe, you know, the target is to, my concept is to treat as much as you can with all the available treatments, and you have either anti-VEGF or steroid. Try to dry the macula as much as you can. If you have some fluid at the end after all this, you can leave it, but you have to, your main target to dry the macula as much as you can. I don't tolerate fluid, I mean.
No one like it. No, unfortunately, some patients, they have to have it anyway, whatever you do.
I think I'll echo the same feelings of my speakers, but I have a slightly different opinion. Yes, fluid is good, but eventually, if you keep fluid in the eye in a patient with DME, it is going to cause damage. So you have results of FAME trial, and you have RISE and RIDE, which show that if the fluid remains for 2 years. So unlike in AMD, where the impact is faster, I think DME, that's a much chronic course where it eventually causes damage. So you don't want fluid to be there for a very long period of time. Yes, you can tolerate some fluid, but eventually that fluid is going to cause harm to the macula in diabetic macular edema.
Okay, thank you very much. Thanks a lot, Prasan. Thank you, Ibrahim. Thank you, Dr. Ahmed, for that night's symposium. And thank you for Novartis for giving us the opportunity for these sessions.